Okay.
You can introduce them.
Okay. Well, first of all, I want to thank Dr. Anthony Piana, who I met in Brazil recently. He invited me here to New York to have a little conference about my personal evaluation and my opinion about breast thermography. My name is Enrique Martin Del Campo. I'm originally from Mexico City, and I'm a certified surgical oncologist there who has been involved actively in the image that is produced under the infrared spectrum, either called digital infrared analysis of the breast or historically breast thermography. So everyone that's out there, it's very welcome to hear us and at any point maybe participate in it. It is a non-profit presentation and it's reserved only for educational purposes. And so here we go. So it's based on my personal experience. I have applied infrared image as a complement procedure or adjunctive in my own private practice. Of course, it does not represent current standards of care or recommendations in Mexico, but at some point it will be available as free PDF in my personal blog that you can write down and maybe visit along the way the next year. It's intended for educational purposes, and all the images are part of the doctor-patient confidentiality agreement during our consultation. So we as doctors have mammography as a cornerstone as an imaging procedure in breast cancer because it's the most solid based on evidence. That's a fact. It's the most complete anatomical procedure of the breast in image. So I think, in my opinion, the following imaging bricks, you might say, will have to come and add up based on it as to construct whatever you want to do afterwards. Recently, I found this comment on the web, Science-Based Medicine by Dr. David Gorski. Unfortunately, thermography has been related sometimes to quackery or fraud, but the best point or the best comment he does at the very last is that it might be useful as an adjunct to mammographic screening. In order to determine whether thermography is useful, we will have to do the proper scientific validation and clinical testing first, which haven't been done. Maybe that's controversial, but will require a large prospective, in my point of view, clinical trials. Okay, so here we go. This is what we know. Thermography will not see microcalcifications because it's not within its capabilities. Mammography, it's very clear defining these microcalcifications. Even radiologists are obsessed in trying to find them because they indirectly represent where a possible tumor can be, malignant tumor. So, for example, mammographic clear detection of this would be suspicious, maybe classified as a VIRAT 4. But if you do the same procedure in the same exact patient, the curved arrow represents where these microcalcifications are. And although there's an asymmetry, probably enough to be suspicious during thermography, anatomically is incorrect in its orientation. So this is where we argue that if it's done initially as a screening, it would probably orient to the metabolic alteration of the right breast. Yet the exact position in the non-dense breast is clearly defined by the X-rays, right? So we believe in screening because of these anatomical considerations of X-rays. Let's say mammography hit first, like Xerox, you can say. So everybody hit Xerox, everything else, although they are making a copy, right? So human behavior inertia of any unstoppable evidence will eventually crash against a challenging force, and some of the pieces will have to fall down. Not everything about mammography is true, as not everything about thermography is true. So what I am trying to do personally is to have some order in these pieces and act in the same direction. Recently, there was a big storm in New York, we all know. Mammography is right now under fire because some of the evidence is challenging the survival benefits, and thermography has always been in the eye of the hurricane. This is the original article published recently November in the New England Journal of Medicine that proves that early stage cancer has been growing because of the detection of thermography. But the red line represents the survival benefit or the late stage cases that come or that have presented in incidence. So this is where, okay, so this is where there's a big question about the benefits of mammography. If it's being able to change anything in this late stage or survival benefits. This is a pyramid in Mexico and the southeast. You are all recommended to go, and they represent history of my country. And I think we should not forget history, because otherwise we'll make the same mistakes and they will be repeated again. These are some historical images about surface skin temperature regarding breast cancer, and of course it's not a new technology or not a new idea. This was back in 1956, I believe, from Dr. Ray Lawson. But they represent, he proved that obviously maybe it's an inflammatory breast cancer over there in the left breast, but he proved with this surface thermometer that temperature was different between both breasts. Evidence was built in France back in the 80s. With this kind of thermal images, he was able to produce some interesting results. But as you might read where the arrows are, they were usually symptomatic patients, and most of them had family history. And he emphasized where the red arrow is that in no case is that a diagnosis of, or was the diagnosis of cancer made on the sole basis of thermography alone. But for him, it did serve as an alarm signal drawing attention to a possible cancer at an early age. But remember, these are people with family history or symptomatic. So we all know, or we all understand how image in infrared has evolved. Back in the 80s, the black and white image was the ones that Michel Guthrie had. And nowadays, we have more digitalized, more sensitivity, and all the computers are fortunately helping us with these images. So what an infrared image can actually see is not only one thing, but the sum of these factors, I think. Angiogenesis, tumors that need to grow are able to produce substances that can fill up more spaces with these blood vessels. They will come with nutrients for them to grow. Cellular metabolism, individual cellular metabolism, and they will represent how active that individual cell is. Dilated veins or arteries and vascular density, and the localized response of the organism against a tumor, that would be inflammation, right? He's trying to fight back against this enemy. So as we all know, or we may suppose, is not very specific, but has a lot of sensibility in detecting maybe the sum of all these individual variables. This is what we tend to or intend to diagnose or detect. In the left breast, we have a very active zone. This is a diagram, of course. And this is a natural, non-palpable tumor in the left breast. There are some important factors here. Maybe you cannot pinpoint the exact region where the lesion is, but you can have an asymmetrical pattern specifically for maybe a high-grade tumor on the left breast. Of course, this is a patient with small breasts. Maybe she's around her 40s or 50s. But it does represent that something is going wrong in the left breast. Okay? So this is little evidence of an static image during a certain day of her maybe menstrual period that it's abnormal. What we argue as allopath, as scientific, as oncologists, as radiologists or breast surgeons is that we have found, or we found a lot of misleading information away from where we are, right? So we do not have any proof, at least we are not taught, that this evidence can be found. So we are very skeptic about it. So it says if infrared mammography that can detect or that can scan much earlier than X-ray, if that's true, I would like any one of you to share this information if you have proof of it. One of the main difficulties of mammography is breasts that are very dense, that are very whitish. So the more dense the breast is, the more things that could hid in it. So for us, meaning radiologists or oncologists, or I mean maybe whoever, it's very difficult to see in a very dense breast. This is Mexico on a very clear day. This is New York, right up there with Storm Sandy coming through. You cannot see anything. And it would be similar if the weatherman is a meteorologist. It's very difficult for him to see. And also for the breast man that would be a radiologist, it would be very difficult for him to see. And as in any skill, it has to evolve during the years. So interpretation skills in any diagnostic imaging, in any field, will take years of expertise in order to have a precise diagnosis, or as I should say, forecast. So I believe expert infrared interpretation for the breast comes after 2 or more years of practicing digital infrared image or analysis as a complementary study in oncology. Here I have my patient in one of our offices in Mexico. I have the ultrasound back there in the negatoscope. Unfortunately, we still use some typewriters, but we have the computers there, and there's the patient referred with a suspicious breast cancer in her right breast. So the big question is there any specific need for digital infrared analysis of the breast? I believe that we do not know its meaning. This is a red kanji that represents different meanings regarding the context it's used in its language. I believe thermography is like a kanji, and not many of us speak Chinese, maybe none of us speak Chinese, but that doesn't mean that Chinese or that Chinese kanjis or symbols do not have a meaning. So upper left, that's the breast cancer kanji, and then you obviously recognize breast cancer in English, and there you have cáncer de mama in Spanish. Some of you might know it or understand it, and that's one of the biggest reasons we do not believe in thermography as allopath, because we do not know its meaning. So finally, after having more than 150 patients with suspicious, already biased patients, I have to say, referred to me as an oncologist, I understood that as an adjunctive procedure, digital infrared image or analysis closely or directly relates to tumor size. Obviously, there are more cells, number of positive lymph nodes, that would be more aggressiveness or grade of aggressiveness. And an independent prognostic factor was that tumors that have a higher score, we might say in infrared image, would have invasion to the vascular space. All of these are prognostic factors in oncology on an everyday basis. So these are a mammography of one of my private patients with dense breast. She had a rate invasive ductal carcinoma, which is very difficult to see because she has dense breast. The white arrows represents the denser areas. That on the left side, you can see, I mean, they're almost actually the same. It's very difficult for it to see. But under the infrared analysis in this particular case, it clearly identifies the interest of area as the highest thermal summit or highest hotspot of the right breast. And you could see the aberrant or superficial veins trying to point out the lesion. So that's a very interesting phenomena that in some invasive carcinomas is repeated. But since in thermography we are trying to measure one breast and compare it to the other, there's one difficulty. Overall, there's bilateral malignant tumors that represent around more or less 5% of the cases. So mammography is very good to identify bilateral tumors. So that would be around 5–7%, right? There's the microcalcifications on the right breast and this altered density on the left breast. Remember, it's only 5% of the cases. In ultrasound, these calcifications are represented also, and on the left breast, there's an irregular solid lesion too that can be easily measured. In our medicine, scientific-based medicine, we believe in size, we believe in solid, we believe in calcifications, we believe in things we can measure, but we do not understand what this actually represents. This is the same image of the previous patient. So although possible, infrared image could have physical limits inherent to its principles to identify bilateral tumors. So that's another question that we will not argue, or we will try not to go into thermography because it has this flaw, you might say. But for example, this is a 2010 BIRATS 3 in a patient who has very dense breast. So her gynecologist recommended obviously a 6-month surveillance, right? Unfortunately, that lesion that was back then 5 millimeters progressed into a 1.4 centimeter lesion. Very difficult to see in the mammography, easier to see, and you can measure it in the ultrasound. And this was actually the thermography basal study, frontal image of this patient. Personally, I believe in the functional study because it gives a clearer, or it defines better the lesion than in the basal study. The vessels on the right side constricted because of this cold stress test, and historically this proved in the past that it gave some false negatives. But I think from my own point of view, cold stress test should be also in the conventional thermography study. So then by anatomy, I compare this anatomical area analysis and make all the measurements that the software gives you. And we have an individual score. So now in 2012, she had these post-surgical and radiotherapy findings or alterations after treatment, the white arrow, but she felt something in the perioral superior undefined lump around 1 centimeter. After after oral chemotherapy and after radiotherapy and after surgery, we went for this, and the same exact vessels, superficial veins were present, more dilated, and then this previous hyperthermia, as you might say, was easily detected. Okay, already existed in 2010. This is 2010. This is 2012. It will be the cold stress test. There it is, with the inverted image. So now that's a unique unilateral persistent functional hyperthermia that is coincidental with the clinical and 2-year previous infrared scan. This is just one case. It's not strong evidence, of course, but it gives me, in my particular point of view, a specific niche where infrared image can help. High-risk patients, previous patients that have had breast cancer in the other breast, surveil the breast that is supposedly to be healthy, familial history, for example. Okay, and this is the mammography eventually that turned out at 2012. The original left tumor on the blue arrow and the secondary neoplasm, different histology, by the way, in the white arrow. There it is. Now it's measuring around 1.6 centimeters. Personally, I even reproduced it in the OR. This lady had recurrence of these microcalcifications that were easily seen under the infrared. She was under guidance to have this biopsy to confirm histology, but previous to this, I performed it just in order to prove that some high density areas or higher density areas or higher metabolic areas can be associated with the presence of these microcalcifications. It may be a little breast or small breast, but she's a very high risk patient again. This is my specific universe because patients come to me when they're symptomatic. And then a few weeks ago, I had this shared by Dr. Piana. She's a lady that she had a nodular enhancement, 6 millimeter, found in mammo and MRI, I believe. And Dr. Piana told me, well, he interpreted there's an area of close vascularity, and an anatomical test is warranted in these cases, and maybe a follow-up study would be recommended, right? So remember, as an adjunctive procedure where non-conventional studies are suspicious or non-conclusive, infrared image can help these patients, I believe. I think any new finding is sufficient enough to have a suspicion. It could be adjunctive for non-conclusive anatomic previous imaging, yet the standard of care demands that this finding or this recommendation has to come from us, the certified breast or imaging specialist. That is why we do not, or we have to understand, sorry for that, its meaning. This is one of my sample cases where it says IZQ, that means left in Spanish. There's a clear radiological suspicion, VIRAS-5, that was 1 year ago, 2.1 centimeters, even palpable, easy. So that's why mammography and ultrasound are the standard of care, because they give sufficient information in most of the cases, maybe 80%, 85% of the cases. And we define anatomy, okay? This is my personal interpretation that gives me, as an adjunctive procedure, additional metabolic information prior to biopsy. In this case, a high-grade, 2 centimeters tumor. I performed in her quadrantectomy, axillary dissection. She underwent chemo and radiotherapy, and now she's under hormone therapy with tamoxifen. These are the pre-treatment series, and the follow-up series. But then she had this complaint about something else. And she showed me her new studies with a VIRAS-3 defined by ultrasound around 12 o'clock in the right breast, with an ultrasound that defined 6 millimeter, 5 millimeter diameter. So I performed the infrared analysis in her. These are very difficult breasts to see under the mammogram, but again, the infrared image was coincidental for this specific alteration of this specific nodule under the ultrasound. So instead of waiting for the 6 months, in this particular case, again, it's a high-risk patient, I recommended her to go for biopsy. So we repeated the ultrasound, and now what seemed to be an ovoidal nodule, it became an irregular nodule. So now ultrasound 3 months earlier than standard 6-month surveillance was recategorized to VIRATS 4A, and it raised suspicion. So from my point of view, this is how we can help. This is a personal view or vision of what will eventually happen if we make hybrid images of thermography and infrared image, because this will have a meaning. I gave them a XIR image. I have shown this to some radiologists, and they have the same look as if they're seeing a Chinese kanji. This is one study performed from one of my gynecology colleagues in Panama. This is a patient with a symptomatic complaint, and I told him, please do not tell me where the lesion is. Okay? Most of us will agree there's something going on the left side maybe. It's very difficult. Okay? So the initial standard, or whatever he sent these infrared images to interpret, recommended a 6-month follow-up, and both breasts were possibly benign, even though it was symptomatic. So this is where it's very, 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 very sensitive when you do not recommend to go further, maybe into invasive procedures, to patients that have either physical signs of the disease based solely or because of the infrared results. Maybe you have read this before or know this before. This is my actual interpretation. So I said to him, well, there's a probable breast carcinoma on the right. Maybe it's grade 2. That would be moderately differentiated in the superior external quadrant of the right breast. And as an oncology, I would say it's on a stage 2 clinically. I would say T2 around 2 to 5 centimeters. And because of the axillary hyperthermal images, maybe lymph node involvement in that area. So I said you have to go for biopsy, of course, even though it's not very clear. Remember, infrared is metabolic, so its contribution should be metabolic, I believe. So digital infrared image of the breast has a biological and metabolic meaning. It means the behavior of an already detected lesion. I think it could only evaluate risk in special clinical scenarios, like familial or personal history of breast cancer, and possibly in symptomatic patients. There's no clear boundary who's responsible for the infrared image, and that's a very sensitive part of the deal also. Most of you are not certified breast specialist or oncologist or radiologist. So who's responsible for treatment and taking care of breast cancer patients? So if the responsibility for breast cancer treatment relies on the standards of allopathic medical care, I believe pure or current thermographers should seek and work together with certified breast specialists to construct responsible forward or prospective evidence. These are some of the missing links. Some of certified doctors, local certified doctors, some of them in Canada, Brazil, New York. I have a colleague in southern Mexico, Gordon Wishar, Professor Gordon, who's in the UK, Dr. Jane Wang in Taiwan, Shekhar Kulkarni in India, and me, and hopefully many to come in the future. Do we need these infrared images for detection? Of course not, right? That's a very big tumor, inflammatory form of the disease. Maybe the patient is in denial. So I would say I don't need that image for anything, not for detection, right? But maybe we could use it for the evaluation of response to chemotherapy in advanced cases. We could see how this patient with an inflammatory breast cancer was submitted, or she had chemotherapy, and then after it, we performed the infrared image again. So maybe after, it could give us the percentage or how it responded to chemotherapy. and that's not detection, okay? Now, the big issue is, can we detect non-palpable positive for invasive ductal carcinoma with infrared images? We believe that in order to recommend any single study or procedure to have an actual or probable impact on survival, they have to be non-palpable, below 1 centimeter. It must be focused to detect this part of the malignant lesions. And unfortunately, in my developing world, or in many parts of the world, lesions are around 5-6 centimeters or more. The following images represent already biased, detected suspicious lesions that were positive for breast cancer. None of them were palpable. These infrared images are clear, yet these findings must be reproduced and scientifically redefined and categorized multicentrically and prospectively. To define specific infrared patterns for some specific malignant lesions, I believe could aid to detect breast cancer in some asymptomatic patients. This is the one you have seen previously. It's very easy on the left. This is another case. It's very easy on the right. All of them were non-palpable. There's the asymmetry again on the left. There you go again on the left. Another one on the left. Maybe that's not so clear enough. On the left. Again on the left. So we have to define what's pathologically asymmetrical, okay? And the only way to do that is to have abnormal mammographies, already detected patients, and then you perform infrared image to identify and to define this abnormal pattern and in which tumors it is actually present. Now, this is a BRAF5 cancer, invisible in the infrared spectrum. Okay, so I would say it's a low-grade tumor. We would have better prognosis, but I should never retard the need for a biopsy based on the thermographic or the infrared image. That would be a false negative, a very clear false negative. This is another case, a very fond patient of mine. She had a positive invasive breast carcinoma that was unidentified in the infrared analysis, even palpable, because it was a mucinous tumor. So these are the false negatives that we do not like as a radiologist, right? So any certified radiologist will say, you see, infrared analysis did not detect it. But the intelligent question for me was, why? Because the answer is related to the metabolic heat generated by this particular cancer. Mucinous carcinoma, remember, are in or embedded in a gelatinous material or mucus. Therefore, infrared radiation is null, but indirectly speaks, we might say, of the biological behavior of this specific lesion. That is why you should go after anatomical imaging procedures, and that is why also it is considered by most of us as useless. Okay. Unfortunately, I come from a developing world where 95% of the normal population do not have access to or do not perform mammography. So as a detection procedure in rural or developing communities, some infrared-specific patterns could help and identify high-grade invasive ductal carcinoma around 1 or 2 centimeters, as is in this case. There's ongoing research already going in Southeast Mexico. Dr. Gutierrez presented it in the American Society of Clinical Oncology back in 2009, and he's still performing it. I believe infrared could also be an auxiliary method for breast exam, and maybe could be useful also in high-risk patients who have breast implants. This is a negative mammogram, a suspicious ultrasound that was already and also identified by the infrared image. By the way, these images are from my mom. She felt this lump. My grandmother had breast cancer back in the 90s. and my mother felt this lump back in 2009. The lesion was not identified on mammography because it was an isodense lesion. It was clearly defined in the ultrasound, so it was identified, but it was also curiously identified in the infrared spectrum. So working together, these three images, I think, can be useful in the near future. Okay, remember, not all asymmetrical infrared patterns mean breast cancer. This is a patient who is symptomatic with breast pain on her right. And finally, it eventually was reported as a mastitis. Inflammatory diseases, benign inflammatory diseases, can also be identified clearly under the infrared, and that doesn't mean that they have a breast cancer. They cannot be identified also by mammography or ultrasound. So either way, they'll have to go under the confirmation of the biopsy or any surgical and pathological report. And there are some special situations where there's a non-conclusive tumor or lesion that is detected in mammograms and ultrasound, and even neoplastic in cytology. Okay, so this is maybe a 1 centimeter nodule of the right breast, difficult to see on the mammogram, not so clear on the ultrasound, even had a fine needle aspiration biopsy. I performed the infrared image. It was very symmetrical. They had the same score or infrared quantitative analysis on both breasts. But although it's invisible, that would mean it's low metabolic, but you should not, never, if it's identified by any anatomical procedure, to stop the need for a biopsy. Final pathological report was negative for cancer. So although it should not contraindicate the need for a biopsy, it gives useful information prior to histological confirmation. And from my own point of view, this gives the patient before the report a little peace of mind. Recently, some clinics have been ordered to stop useless breast cancer tests because it's very, very, very controversial. And this in particular image took me around 2 hours to reproduce or to write. On the right side, we have this pyramid of the possible number of patients, and on the left side, we have the possible benefit. The most who benefit from infrared image would be those sporadic conventional errors on mammogram and ultrasound that this third opinion being infrared would detect as cancer. High-risk, dense breast patients, 40 years and lower, maybe as an interval procedure would have more benefit. And then you move down to mislead women seeking infrared for screening. Because it's metabolic procedure, it's very difficult to recommend it if you have mammography available to be a substitute for mammography. So the most ethical thing to do is to go to an immediate referral. And all of the others are different clinical scenarios about the possible number of patients and the possible benefit. But I believe all women will benefit if new evidence demonstrates that thermometry holds a useful meaning of any kind. If current standards of screening recommendations eventually broaden from annually to 2 or even 3 years, that's normal population risk, all patients could benefit being referred to an oncologist if they are going to be submitted to a biopsy, because infrared offers a powerful, comprehensible image that has an actual meaning. We, the oncologist or the gynecologist or whoever is taking the biopsy, may not change the algorithms, but in my case, it gives a better comprehension of the same biological phenomenon, that being breast cancer. In most of the cases, patients understand the infrared image, so it gives more empathy and more compliance are enhanced when it's properly done. And at the end, I believe science will benefit of the analysis of these images, because infrared images represent human body quantitative biological information. So if it's a complement, should be a complement for you, but should also be a complement for us being the certified allopathic doctors. If it's metabolic, that would mean that its contribution should also be metabolic. I believe it should act in synergy with all of the other different kind of images. Should be comparative down to the pathological report. You have any case, you should share it. I should share it. Who can be benefit also? All patients submitted for biopsy to define the infrared breast cancer, though it must be re-standardized. Maybe, since it's almost fully digital, there should be an automatic analysis to have a more solid information. Initially, I think it should be free, prospective, and under controlled studies to construct real evidence. This is one final comment I have. If a digital infrared analysis obtains a numerical result, being that in degrees, from a given object, shouldn't it give a finally mathematical result? And if it's mathematical, then maybe human individual interpretation should be avoided at first. Maybe in the future there should be the help of an automatic procedure, and for them to be analyzed together and have a very close or homogeneous criteria. After all, I think the common enemy it has always been breast cancer. We should not stop screening with mammography. Now it's under fire, how many, at which frequency. But I really believe that if this is a war, infrared analysis could help against it. Some of the guidelines are confusing. Every 3, every 2, starting at 40, starting at 50. But the conclusion is that all women should discuss the risks and benefits of screening and get a mammogram, an infrared, an ultrasound when it's scientifically proven. I believe it should be reserved for highly trained specialists because of all of the previous comments. And breast cancer that is also defined in the infrared spectrum, could have this ribbon, maybe. That's a proposal, a personal proposal. Thank you very much for listening to me. This is my email and my blogspot, and I'm willing to help you and have close contact with you in the near future. Thank you very much.
Thanks, Dr. Del Campo. Excellent job. As you can see, he's got tons of information out there that we need to all learn about and work together. We are going to open up to some questions here. I'm Dr. Piana, and I would like to start out maybe a couple of questions. I think Dr. Del Campo and I will be going back and forth all night with questions and so-called debates. Any of you are welcome to join us for dinner tonight in New York City if you're nearby. But I do want to address a couple of questions to Dr. Del Campo myself, and we'll pass the microphone back and forth as we talk, since we're sharing one computer here. I want to make an analogy to mucoid tumors leading to the comment of uselessness for thermography, as inflammatory breast cancer is to useless mammographies. And I don't mean it as a useless mammography. I'm saying if you're going to label one as useless because there's one aspect of testing that doesn't stand up properly, like in a mucoid tumor that's insulating the infrared being emitted from the tumor, then you would have to have the same fare for an inflammatory breast cancer that may not show up on a mammogram, or other types of cancers that either don't show up or are blocked by the densities of the breast. All right, so I'm going to try to make it a two-part question so we can cover two questions at once. At the same time, actually, you know what? I'm going to leave it at that. Why don't we answer that one first, Doc?
Okay, we consider it useless because it's not clearly seen under the infrared, or it's invisible, right? Inflammatory breast cancers are clinically very symptomatic, but most of all because we do not know the meaning of the infrared image. We tend to parallel mammography and detection, but I believe infrared can be involved or be equal to diagnosis. One thing is detection, the other thing is diagnosis, and the other thing is therapy or treatment. So the most clear for me in detection would be mammography when it's properly done. And as a complementary procedure, infrared images would help me in the diagnosis prior to biopsy. It gives me a useful, let's say a third opinion or an alternative way of seeing things. It gives me a faster comprehension of what is really happening or what is actually happening in the patient that is sitting in front of me. And I can in some specific scenarios, for example 4.9 tumors that are 2 millimeters away from being a T3 or tumor 3 category. If it's very, very, very hot, then maybe I will not operate on that. Maybe I would go for the chemo first, even though it's 4.9. So there are these limits and boundaries that infrared or where infrared image can give useful information. I do not believe any of the images are useless because they have the use. But since we speak mammography first, if we don't see anything in the infrared or if we see more things on the other breast, we would say, you see, that's useless. And that's because we do not understand it at first sight.
Okay, Doctor. I figured that would be your comment. I know you don't really think it's useless because you're using it, therefore it would speak for itself, the comment. One thing I do want to say, and you might not be familiar with this because it's mostly in the U.S. that we're seeing it, but we're getting reports from radiologists out of New York City. In the body of the report, or I should say at the end of the body of the report, they're stating that 15 to 20% of all tumors are missed on mammograms. Okay, they're putting that down there as sort of a disclaimer. Okay, so in light of that, my question and my proposal, and I think we're on the same page with this, I call it the trinity of screening, so to speak, where you have ultrasound mammograms and thermology all in the same triangle. One might miss 20% here, the other one might miss 11% there, and so on and so on. Therefore, if we put the three together, and I know you're saying this, okay, but you might not be saying it for screening purposes, you're saying it more for symptomatic patients and whatnot. But for women under 40 to 50 years old, especially in countries like yours where you have larger cancers being detected, or Africa or places like these where they don't have access to mammograms, it's a more affordable approach to be able to use this as a screening, at the very least for women under 40 to 50 years old, if not combined with the others over 40 to 50. What's your opinion on that?
Well, Dr. Kaiserling, back in 1998, he proved that when you add thermographic images to standard or conventional procedures or images, raised sensitivity from 85% to 95%. Okay, so he said it. I think it does. It actually does. And this disclaimer that is written in the mammographies around 15%, 20%, depending on who's interpreting it. They are written because of legal purposes, right? Because you don't want to get sued eventually if you miss a cancerous lesion. I think adding up a different approach or a different strategy would help. It's a different weapon, we might say, in this war. Digital mammography, tomosynthesis, positron emission tomography or mammography, and so on, are very good weapons in this war. Let's say there are atomic bombs. Unfortunately, most of the countries cannot afford to have an atomic bomb in every county. So, and it's very complicated, right? It has specific indications. It's very complicated. You have to do complementary ultrasounds. Patients in my country are detected maybe in March, and they will go for treatment 6 months later, and that's a national statistic. That's very difficult to shorten this period of times. So I think that we should change the strategy, because although we have tried to do the same things for the past 40 years, we have not changed anything in our countries. We know mammography has changed statistics in the Nordic countries, specifically Sweden, we will say. But I'm sure that breast cancer statistics or breast cancer population or even women population are not the same in Sweden or in India or in China or in Brazil or in Mexico. We do not have the same economical opportunities. We do not have the same cultural opportunities or educational opportunities. So infrared image, although maybe could be scientifically wrong from the objective point of view, it will be socially correct if someone gets benefited from it. It's cheaper, you might say, it's more portable, and it would approach this healthcare issue around the world. It's very difficult to do, but the only way to prove it is going forward and give it, I think, another chance.
Great, Doc. Let's open up some questions to some people out there. I want you to write your questions down in short. It doesn't have to be the full question, so I can see what's out there and what people are asking, if anything, that is. I know we've done a fair job of covering everything, but if you have a question, I'll screen it first, and then I'll present it to Dr. Del Campo here. So if you do have anything, please let me know. I think we have one here. Let's see. Okay, we covered that. Okay, we covered that as well. Dr. Jeff, I think I'm going to put you on because you're always full of wisdom. I'm going to let you ask a couple of questions. Please understand there are some fundamental differences in perhaps your thinking and his, but this might be interesting. Let's go.
Hello. Hi, Dr. Jeff.
Jeff, you there? You are unmuted, Jeff. Do you have your microphone on? We will mute him. Sorry. False alarm, guys. All right. Oh, no, Mike, he says. Okay, well, that's okay. He has some questions, and I'll just shorten them up here. He's saying and everyone, I think, has this opinion that are more alternative-minded. We talked a little bit about this earlier, Doctor. However, how do you feel about the radiation risks of mammography versus the risk-benefit ratio? Why don't you comment a little bit on that?
Well, as a standard doctor, you might say, or a standard health provider, we have had radiation procedures, X-rays for the last, I don't know, maybe a century or more. And there's an inherent damage from radiation, right? I do not believe it's sufficiently enough to cause cancer if it's correctly done, if it's a low radiation. It's a scientific and physical principle in nature that has helped us involving many pathological diseases in bones, in lungs, and whatever you want to apply them to. So radiation for me right now is not a very important issue. And I would say, what about the technicians that perform mammography every day? They could perform, most of them are ladies or women, they could perform maybe 30 or 40 mammograms every day. They are exposed to radiation. Until now, I haven't had one single technician with breast cancer that I can remember. So it's a very low dose. There are some arguments against this, of course, but in my personal point of view, I think the benefit, it's more than the risk of having any harm about radiation and about pain and about contact. Why? Because the common enemy is breast cancer. So I think it really doesn't matter how you pick it up. If it's a breast exam, if it's ultrasound, if it's infrared, if it's mammogram, the common enemy eventually will be breast cancer.
Yeah, very good. And of course, we still have the great debate out there, whether it's 40 or 50 years old to start your first one, whether it's every year, every 2, or possibly every 3 years, according to the Canadians, up to you're 74 years old. So maybe part of that is to reduce the exposure time. I'm not sure what their thinking is. I know the age increases. I think it was because of the dense breast issue. Is that why we do that, Doc?
Mm-hmm.
Yeah.
Right.
And so I guess, perhaps you have to draw your own conclusions from that. However, I think my greatest concern with this all is, and Doc, I don't know what you do in this case, but it's mostly, I think, the radiologists that do it. A woman that's had breast cancer, a woman that's suspicious, they're going to every 6 months for 2, 3, 4, 5 years to detect, for mammographic testing. So maybe not the ones going every 1 or 2 years might not have a high risk of obtaining breast cancer, but what about the ones that are going every 6 months? What do you think about that?
These are maybe the highest point of the pyramid in the population. These are a very small group of patients. Mammography is the standard of care. Mammography, although it may, I'm not saying it's harming, it may harm some maybe genetic predisposition altered genes to eventually transform themselves into cancer. It's our basic language. So if you have a very high risk and there's a suspicion under mammography, I don't see what's the difference doing it every six months. We're fighting against the risk, and we're seeing it through mammography. So we're not going to order any different from that. So again, I don't think every 6 months, because of the low dose of mammography right now, should harm anyone. Of course, there are some recent publications involving these specific genes and the radiation, exposing them to radiation, but this is just a single article that I've heard from, and if this is true, I don't think it will be for everyone, just a specific particular clinical scenario.
Okay, Doc, I think we've pretty much answered all the questions that I see on the screen. Once again, thanks to Dr. Del Campo. Please use him as our resource here for education. I know he's going to be involved with PACT again in the future. We're certainly happy to have him come to New York, and like I said, we'll show him around the town and have some good food tonight. But in the future, please let's spread the word about these. I know it's 2 o'clock in the afternoon. I know we have another 50 people watching tonight when it's recorded. So we're off to a good start, but this is information that needs to be throughout the whole thermographic community. And for some reasons, to dispel some myths and also to open up some thinking on everyone's behalf. So it was a great end of the presentation debate here. I'm sure that will go on the rest of the day. But thanks for coming, and we'll start the checkout procedure now. Lee, you're in charge, and we're out of here. Thanks, Doc.
Thank you. Thank you. Thank you.